because it's been 10 years since I left. At Wangler, and I was the former CEO of the first year. I was here from 1999 to 2013. I lived this hospital. I loved the work we did and our results. I was never too sure about Essentia, but that was the system that employed our exceptional medical staff. You remember them, Dr. West, Dr. Swanson, Dr. Mitchell, wonderful people, good doctors. And from what I've been hearing in the meetings we've had, you still have good doctors, you just need more. So anyway, those doctors worked for Innovis, which joined Essentia Health, so that seemed the system that we should develop an agreement with. It seemed obvious that if we could strike an ironclad agreement, then it made more sense than working as two separate entities. These are the things I know, and this is a note I took from the statisticians that presented tonight. Richard's stats apply to his level of facility. Those stats include the high-risk patients that the doctors here send to him. That's why his rates are so much higher. And if you saw Cassie's stats, her stats for level 1 identify why you don't have 50% of the market share, because you send those patients to Essentia. So I need to clarify that, because that is a fact. Anybody can make stats to say what they want them to say, and all of a sudden it looks really impressive to the people that don't understand what is all involved in those stats, and the wrong decisions and the wrong choices get made. So I want that to be very clear. Richard's stats were skewed and included the high-risk patients from Fosston. Other things that I know, Fosston is a real hospital. It is not just a transfer station. Fosston is an excellent hospital. This hospital has received numerous and various awards, including top 10% in quality, top 10% in customer satisfaction, top 100 hospital in the entire USA. I'm not sure if anybody else in Essentia has reached that. This type of results take caring, commitment, vision, training, and the dedication of excellent staff to be and to compete with the best. Why is this hospital so important? Why would I drive for 2 hours to talk about Fosston that I left 10 years ago? Because I still am passionate about rural health care. Rural health care is vital. To have plentiful high food, which I can tell by looking around this room when I came in, we all eat plenty of. We need farmers, and we need egg. Where do you think the farmers come from? Not from the center of Fargo and not from the center of Duluth, I can tell you. To have plentiful, high-quality food, we need healthy people to produce the food. These people want a quality of life. And because we spoiled Americans in this so far land of plenty, take what we have for granted, the quality of life of the farmer and ag-related businesses is often in jeopardy. Ag and related manufacturing and the services to support them is what this community is all about, and they are good at it. So it's important to value ag and ag-related business by providing health and education services. I'm not just talking about health, education too. These people need a lot of knowledge and a lot of information to do what they do today. These are not inferior people. These are some of the best and the brightest. And education services that enable the people that love working the land and provide food to continue to be able to do so. And at the same time have a quality of life. It puts food on all of our tables. Cheap food relative to the rest of the world too, I might add. And it's important to really start working on this 20 years ago. And in this affiliation agreement, foreseeing what's happening today, we did. stage, and I'll tell you why in just a minute. Too many rural Americans live in healthcare deserts, in particular at this time obstetric or maternity healthcare deserts, a trend that began many years ago. We cannot become one of those deserts. In fact, legislatively, we must work to reverse this dangerous course across the USA. This concern is already being addressed on national news and by legislators. They know small hospitals need to deliver OBs. They know that. They know they need to screen them for risk, but they know that it is dangerous for women to have to travel 40 and 50 miles, maybe in labor, maybe with a complication that could have been dealt with earlier, maybe because they haven't even seen an obstetrician or a physician, because they would have had to go too far in the first place. All very dangerous things. And I believe Evan did just a great job of showing that, and Cassie a great job of showing those stats. Today, women in labor often have to, so I'm going to be a little bit redundant. Today, women in labor often have to be driven 40 to 50 miles in any direction to receive OB care. If a storm is expected, this may require staying at a relative's or in a motel in advance, or taking a chance that labor will not begin till after the storm is over and the roads are open. This may not be the first child. This may not be the first child, and what happens to the other children during that time? These are all factors that impair the rural quality of life and the food of plenty on our tables. Also, there is a problem with access, as many patients cannot go 40 to 50 miles for each visit, and so they delay and forego visits, which may result in high-risk pregnancy where it otherwise could have been managed. I've heard before about shared obstetric care. It does not work. Which doctor in Fargo is going to put him or herself at risk by never having seen an OB and receiving it from another doctor solely on his analysis and assessment of that person? Nobody. Nobody. So that doesn't work. In high risk, okay, because we care, small hospitals that do OB already screen and refer high-risk patients do an excellent job of screening. In fact, they lower their market share dramatically just so OBs are safe when they deliver. In my 14 years at First Care, I remember very few. I don't think there were enough to count on one hand, emergencies in labor and delivery. And those were not foreseeable emergencies and would have occurred in any facility, and even worse, in transit. These emergencies were all managed as effectively as they could have been anywhere else. None resulted in death. We knew when we very diligently wrote page 8 of the affiliation agreement that there would come a time that Essentia would want to eliminate OB, and maybe surgery next, in particular. And that cannot happen in this town. It cannot happen because of the language of this agreement. And I refer Essentia to page 8 of the affiliation agreement, which spells out exactly what core hospital services must be retained under this agreement. Why did we anticipate this situation? I can tell you, it's not about risk. It's about greed and money. Both are ailments of systems. Large systems cherry pick for profit. So maybe OB doesn't make money, but you can get it elsewhere. You can figure out how to do things for the best health care of the community. However, that often is not the way systems count that. It doesn't make money in a critical access hospital. It's not a Medicare service, and it's largely a Medicaid service. So it stands to reason that might be at risk. We knew that. Small hospitals look to provide service. Large hospitals look to make money. It would behoove people to review the quality of care and outcomes of hospital systems. It may surprise you to find out that some of the largest do not have such great outcomes. Bigger is not always better. And yes, an overall profit is necessary to keep operating, but each service provided should not be evaluated on profit. Each service should be evaluated on the basis of the quality of health and life it makes for its constituents. While Mr. Weispenning can speak to the current quality, I am here to tell you that during my tenure we provided excellent quality of service and made a big difference for people. I have no reason to believe otherwise now. Essentia needs to show absolute proof and risk to even consider thinking about termination of services. And before that happens, due diligence to the words of the affiliation agreement indicate they must put in the effort to upgrade the services if necessary so they can be continued. In this modern era, there is absolutely no valid reason that an OB in pregnancy, during labor, and after birth should drive 40+ miles to see her doctor and deliver a baby. That is, unless they are high risk. We do want the babies and the moms to be safe. To me personally, and as I see it by the people here present, this is a devastating course of action Essentia is undertaking, and it must be stopped. Thank you, Mr. Mayor.